Hey, everybody. My name is Kevin Henry, editor-in-chief for drbycuspid.com. Thank you so much for joining us for another episode of the drbycuspid.com podcast. Tonight, we're going to talk about a really important topic, and that is how we approach research, how we approach articles being written, and how we approach the way that we learn and maybe should be learning as well. And I'm thrilled to have back on the podcast, Dr. Chris Smiley. Dr. Smiley, how are you, sir?
Great to see you, Kevin. Thank you for having me back. Never thought it would happen.
I'm glad to have you back, especially after our last talk about journalism, AI, where everything's going. We're going to link to that in the show notes because I think it's a very timely topic, and I'm glad that we tackled that earlier. But before we dive in, Dr. Smiley, while I've got you on the hot seat, would you mind just introducing yourself to our audience, please?
Sure. Well, I'm Chris Smiley, and in this capacity, I, along with Dr. Abt, are the co-editors for a collection that the California Dental Association Journal is going to be publishing in December, and it's entitled All the Care Your Patients May Not Be Receiving. And in this, Elliot and I got to know Elliot through ADA evidence-based dentistry and EBD champion volunteering. And we had selected a lot of I think, Elliot, we had 11 or 12 different content experts addressing 11 of the most critical, at least in our estimation, evidence-based guidelines that aren't being adopted. And so that's me. Elliot, tell them about you.
Dr. Abt, please.
My name is Elliot Abt. I'm a general dentist from Chicago, a longtime member at the Illinois Smiley Medical Center.
Well, gentlemen, I'd love both of your opinions on this question I'm getting ready to ask. And Dr. Smiley touched a little bit about what we talked about last time. But in this era of technology, AI, everything else, why is evidence-based dentistry so important now?
Well, I think it's interesting that you lead with AI, because AI is not a research database. It's not going to give you citable, curated evidence. Like if you go to PubMed or other databases where you're going to be getting citable research articles. And what we're doing here with our collection is that we're looking at clinical guidelines, and these clinical practice guidelines are kind of the highest level of evidence. So if you take a look at what you get from AI, it's just a word salad, right? It's made to sound good. But here in a evidence-based guideline, that is typically based off of systematic review. And a systematic review is a gathering of people who find a clinical question and they determine all of the parameters in answering that question ahead of time. And then they go out and they search the literature, and basically they filter it down to what's important. And that's what gets into a clinical-based guideline, is filtering down that mound of evidence into something that's important.
Dr. Abt, your thoughts?
So evidence, it's not really all created equally, as you may know. We have lower levels of evidence, including observational studies, and then we have randomized controlled trials. And then above that, as Chris mentioned, systematic reviews. And sitting at the very top of the pyramid are the clinical practice guidelines. And for good reason, because it's a panel that comes together, as Chris mentioned, does a thorough search for all the literature. And now what the guidelines basically give clinicians, the public, the profession, and policymakers is two deliverables. One, of course, is a summary of the evidence. Here's all the evidence, doctor, on this topic. And the second deliverable is a recommendation for or against a certain activity. For example, doctor, we'd like you to start doing something, i.e. placing sealants in appropriate cases, or doctor, stop doing something in the case of maybe giving antibiotics prior to a dental procedure for a patient with a prosthetic hip or knee.
Gentlemen, do you all find that there's a difference in the generations whenever it comes to adopting and maybe even leaning on evidence-based dentistry? I'm curious.
Well, from my perspective, it's like anything else in terms of a change management and a change of behaviors is pretty difficult for us humans. So now that it's being taught more in the dental schools, there is more adoption, I think, of evidence. But it takes time. In some cases, there are well-documented cases where we have science but there's a lag time of maybe 15 years or 17 years before it's actually implemented into practice. And that's a whole lot different than, say, if there's a problem with a certain airliner, those planes wouldn't be grounded the very next day. So we have a problem in healthcare where we actually are aware of something. It may take quite a long time to actually adopt it in clinical practice.
And I would agree that there are just so many, when you talk about generational differences, I don't know as though that's necessarily fair and that you could have early adopters at any stage in practice, people who take things on because they are inquisitive and they want to learn or they are intrigued by a topic. But yes, you definitely run into barriers such as people just, they have habits. This is the way we've always done it. Or you don't get, things adapted into practice, such as the antibiotic prescribing that Elliot noted, where patients have a certain demand. And, I just say, well, I've always gotten this antibiotic pre-medication before my appointment, and I want it again. Or you may even find an issue cross-discipline, where you have an orthopedic surgeon who is old school and hasn't changed in their ways and still insists on having their patient pre-medded before they have their teeth cleaned. Elliot's absolutely right that we take a look at, in medicine, we're not alone. In medicine, there's typically a 17-year lag time before new evidence gets adapted into practice. And dentistry is no different. And frankly, our patients deserve better.
You all discussed the lag time, and I'm curious, as we head into 2026, is this, if there is such thing as perfect timing, the right time for this journal collection to come out through the California Dental Association?
Well, yeah, I mean, one of the frustrations I think that we have in the world of evidence-based healthcare that we already touched on is, to be able to implement evidence into practice, number one, you have to be aware of the evidence. And that is a big problem right there. And we do know scientifically, just because you publish something in a journal you cannot expect or assume that people are going to have read this, let alone be able to decipher the evidence and then implement it into practice. And that's really what guidelines are all about, is we want to increase the awareness, and that's what this series is certainly trying to do. But publishing alone is not enough. Thus, podcasts like this and other things that can really increase awareness so that ultimately, we're trying to improve outcomes of care, and that's what guidelines are ultimately intended to do. And as Chris mentioned, it's also, we're fighting this clinical inertia. Well, gee, I've been this way for 10 years or 20 years. Why should I change? So there's a lot of barriers that, and it's a very difficult process because, we have a product out there, but we really now want it to be implemented into practice.
And, it's, I think, very cool when you talk about at this time. This is a very intriguing time when it comes to science and healthcare. And I think that, it's very important to understand that these clinical practice guidelines, as Elliot had said, it's based on the highest level of evidence where things have been sifted through. But what that means is that the experts in this situation have done the critical appraisal of the evidence to get to their recommendation. And critical appraisal, especially for a busy practitioner, is something that is an issue because it takes time. And, to put it simply, if you take a look at where you're getting your news source, okay, are you getting it from The Onion or are you getting it from the LA Times or something like that? There's a different level in your source that you would appraise. You'd also take a look at, say, the age of a study. And I think that's a very important thing to take a look at. And we address it with one of our clinical practice guidelines. And it's one that I was involved with publishing when it first came out, which was on scaling and root planing for periodontal disease. Now, that is a very good practice guideline. However, it's more than 5 years old. And so things age. And so you have to appraise it to say, okay, what was the source? Oh, it was the ADA. Pretty good. Who was on the panel? All these experts. That's pretty good. But let's take a look at this. Look at how old it is. And then you start sifting through that and seeing that some of the adjuncts, the medications that are mentioned in the original guideline, are no longer available in the marketplace. Okay. Or there are other facets of the guidance that's in there that maybe don't gel with what is standard practice now. So you don't take all of this at face value. You still have to go in and look at the research and the evolving research. Now, what is going on now is a partnership called the Living Guidelines. And the Living Guidelines are a partnership between the ADA and University of Pennsylvania and others, where they're leveraging artificial intelligence and taking a look at bringing out awareness of new evidence to then reassess with experts what is in the guidance and to update it. And those are things that I think clinicians need to be looking at and being willing to go to this source, California Dental Association collection, to find out about it, wet their whistle, if you will, read the guideline and read the summary that we have in this collection, and then say, I want to learn more, and then go to the full guideline that's perhaps on ada.org, check that out, and then go to perhaps investigating the citations that are in that, or look at other sources for information.
Is there a way to measure success? And is there a goal maybe for what comes next after this collection?
Great question. So in other words, it's the ultimate oxymoron. What evidence do we have that evidence-based practice changes outcomes? But we do have examples certainly from the medical world that following guidelines reduces morbidity and mortality in certain areas, especially in cardiovascular disease. And there's other examples as well from the medical world. We don't have quite as many from the dental world, but some of the summaries that we did do address even some major public health issues in number one, the opioid crisis, and number two, the indiscriminate use of antibiotics. So we already have data that from some of the studies in the dental literature that dentists have reduced the number of antibiotics they're prescribing. In many cases, antibiotics are unnecessary. And so if they're not beneficial, you have to look at the other side of the ledger, which is harm, not only on a patient level, but on a societal level. Some people say, well, what's the harm if I just give an antibiotic? But if you give it and the guy across the hall gives it and the person down the street and then nationwide gives it, now we're back in the soup of indiscriminate use of antibiotics. So we have a couple summaries there. We have one on pain management, which is pretty clear now that if you give a non-steroidal anti-inflammatory such as Motrin, Advil, along with maybe an extra strength Tylenol, you can avoid narcotics. So these are some of the major issues that can really improve public health, as well as, other areas that we've looked at. But yes, we do have evidence that guidelines do improve patient outcomes.
Dr. Smiley, anything to add?
I think that's key, especially the one on opioids. I think antibiotics and building up of antibiotic resistant and resistant strains, which can be a huge threat to public health. But if we look at where we go next, what these clinical practice guidelines, and hopefully through our executive summaries that we're putting out with California, what we're trying to do is reduce variation in care across the board within healthcare, within dental care. And we want to accelerate adoption of these proven evidence-based approaches and interventions, and that should improve patient outcomes. And of course, that's all blended in evidence-based dentistry with the patient's needs and values as well.
Well, again, this is going to be through the Journal of the California Dental Association. This is going to be out in December. We will have a link to it in the show notes when it is live. That way you can find it very easily. And gentlemen, I appreciate your efforts, and I certainly thank you for joining us to talk about this tonight. It's a very important topic.
Thank you, Kevin, and thank you, Elliot, for co-editing this. I think it's a great collection, and for every single one of our experts who contributed their summaries. This is a great collection.
Yeah, a lot of hard work was done. Yeah, thank you.
Well, thank you both for the hard work, and thanks to all the experts that you worked with as well. To make this a reality. We will have more on this on drbycuspid.com, so make sure that you're checking that out. We'll have links and show notes, as well as the article. If you're reading this on drbycuspid.com, should be very easy to find. Till next time, it's Kevin Henry, Editor-in-Chief for Dr. Bicuspid, signing off, and as always, wishing you nothing but success. ahead.
Thank you.